in chat box if I'm not audible. Am I audible? Hello, everyone. Okay, fine. Okay. So, yeah, great. So today we'll be discussing some questions in prosthodontics, and in between you can ask me doubts if you have any. Your mic will be muted, but you can message me in chat box. We'll have a discussion in chat box, and if you have any doubts, if you want to clear something, you can message me in between the sessions. We will clear it. So I'll introduce myself. I'm Dr. Prashant Manohar. I'm a prosthodontist working in northern part of Kerala. So we'll be discussing prostho. Actually, I have posted in, many of you are there in our WhatsApp group. I have posted the question in morning itself. So we'll be discussing that 8 questions today. Okay, we'll go to the questions first. Okay, so in this, I want an interactive session. I don't want as a monologue. It should be a dialogue. So I want a response from you all. You can message me. So you have seen this picture now. I think it's clear for you all, right? So in this picture, there's a prosthesis. Yes, it's a fixed prosthesis. And in the options, it has been asked to identify the prosthesis. So what type of prosthesis is shown in this figure? See, now the pattern of NEET has been completely changed. Earlier, it was description questions. Now they have been changed it into picture questions, more of a picture questions, more of clinically oriented questions. Okay, so you can expect these type of questions more from prosthodontics in the coming years. Okay, so what type of prosthesis is this? Anyone? Is it a Maryland bridge, Virginia bridge, cantilever bridge, or a Rochette bridge? Anyone? You can give a guess. Cantilever bridge. Okay, somebody has answered it as cantilever bridge. Cantilever. Another person, yes, somebody has told it as Rochette. Okay, now we'll discuss. So first of all, Maryland bridge, Virginia bridge, cantilever bridge. Cantilever bridge, it can be in different forms, and Rochette bridge. See, Maryland, Virginia, and Rochette, they belong to a particular group of fixed partial denture known as resin retained fixed partial denture. In this, cantilever can be also a resin retained cantilever bridge can be also possible. Clear? Now we'll discuss each options. So coming to what is resin bonded prosthesis. So it is basically they are luted or bonded to enamel which has been etched. So it will provide mechanical retention with the help of a resin cement or composite resin. Clear? So they are resin bonded prosthesis. Basically, 3 types of resin bonded prosthesis are the Maryland, Virginia. Any doubts in between, you can just message me. We'll repeat it again. Okay, that is how we continue our session, right? So that is resin bonded process. Now, cantilever bridge, it can be resin bonded, it can be cement retained also. Cantilever means, you can understand one the word meaning. It is supported only at one end. Okay, usually bridge, it should be supported from the both ends, from the mesial and distal sides. Okay, but here it will be either in the mesial or in the distal. Okay, now what are the advantages of a cantilever bridge? Say, definitely you can reduce one retainer. Yes, you can reduce one retainer. It is more conservative. So they are used for replacing single tooth. Understood? Clear? But the problem with cantilever that it is having support just from one side. So the retention from this particular process will be less because it has a retainer only on one side. That is cantilever bridge. Okay. In the picture, try to remember the picture. If you want, I'll go it back again. Definitely it is not from one tooth. So it is not cantilever. It is definitely having two wings. You have two wings. One particular tooth has been replaced, the central incisor, and you have some wing with perforations. Try to remember all these things. You have some wings in the lingual aspect with, you have perforations. You can see the perforations, right? You can see the perforations. So lingual aspect, you have a wing with perforation. So it is not cantilever. You understood what is cantilever, right? Now coming to Maryland bridge. See, try to remember the picture also. Maryland bridge, yes, they have a wing. It is resin retained FPD, fixed partial denture, used to replace single tooth, but they have a wing which is not having any perforations, Now, how they will get retention? They get micromechanical retention by electrolytic itching of the internal surface of the wings. So you have micromechanical irregularities created by electrolytic itching. So the wings will be thinner and there won't be any perforations, and retention is by micromechanical interlocking of this irregularities with the tooth and the cement. Okay. So that is how Maryland bridge get retention. So Maryland bridge is having a metal wings without any perforation. So in the picture there was a perforation, so definitely it is not Maryland bridge. Clear? Now coming to Virginia bridge. Virginia bridge, it is fabricated with a technique known as lost salt technique. Now what is this lost salt technique? See, you have the wings, clear? You have the wings, and the internal aspect, you have to create some micro irregularities, clear? And in Maryland, it is created by electrolytic etching. Now here, what we do is, while fabricating the metal wings, we have to make the wax pattern, and it has to be casted, right? Before casting, what we do is we embed some salts which can be dissolved over the wings, over the inner aspect of the wing. Okay. Now what we do is, before getting it casted, we dissolve these salts. So because of this, we get micro irregularities due to the dissolution or the dissolving of the salt over the wax pattern on the wings. Clear? And after that, again, we make another procedure which will increase the micromechanical irregularities by air abrasion or sandblasting with aluminum oxide, alumina. Okay, so this has more micro irregularities, so it will be more retentive. Understood? So Virginia bridge, it is fabricated with the help of lost salt technique, and here also there is no perforations in the wings. Clear? So again, the picture shown is not Virginia bridge also, right? Now, what is the other option? Yes, it is Rochette bridge. Rochette bridge, yes, it has both micro and macro retention. Due to the perforation, you have the resin bonded or the resin blowing through the funnel shaped perforations, and this will provide a greater retention compared to the other two. Okay, so the wings will have perforations in Rochette bridge. Now hope it is clear. So the prosthesis shown in this figure, it is Rochette bridge. Clear? So I think it is clear: Maryland bridge, Virginia bridge, cantilever bridge, and Rochette bridge. Clear? Hope it is clear. I want response. I have told you it is a discussion. It is not a unidirectional lecture. Clear. Okay, fine. So shall we go to the next question? So, okay, fine. Andes law. See, we will be discussing very basic questions, but these all questions have been asked. These all questions have been discussed in or has been asked in your previous exam. Yes. Simple question, direct question. Andes law is used for selection of. Yeah, definitely. Many of you have answered it correctly. It is abetment. Now we have to know what are the parts. We have to know what are the parts of an FPD. Pondic. What is pondic? What is retainer? What is retainer? I think this is a very simple question. Many of you answered. What is abetment? Okay. So components of FPD. See, abetment, the tooth which provides support or retention for which gives that support for the fixed prosthesis is the abutment. So it is the tooth to which we will attach the prosthesis. Understood? That is the abutment. Now, the artificial tooth which replaces the addengerous region, that is the pondic. Okay. Now, over the abutment, we need to, some attachment should be there for the fixed partial denture so that we can attach it over the abutment. That portion is known as the retainer. Clear? So, FPD has got, fixed partial denture has got three main parts. Basic things, many of you will be knowing this. Okay. Pondic, retainer, and this pondic and retainer will be connected at a junction, and that junction is known as the connector. Understood? So the joint connection between the pondic and the retainer, it is the connector. And these connectors, different types of connectors are there. We'll be discussing it in the coming sessions. Okay. All these things will be taken in detail. All these sessions, means all the prostho sessions, we'll have a detailed discussion of each and every topic. Okay. So it can be rigid, it can be non-rigid. We will discuss all the situations where we will use the rigid connectors, where we'll go for the non-rigid connectors. Okay. So now coming to Andes law. So what is Andes law actually? Andes law states that combined perisegmental area of all the abutment teeth supporting a fixed prosthesis, fixed dental prosthesis, should be equal or greater than the perisegmental area of the tooth or the teeth to be replaced. Simply, it means that all the perisegmental area of the teeth to be replaced, it has the combined perisegmental area of the missing tooth. It has to be either equal, or the perisegmental area of the abutment teeth, it has to be greater or equal to the perisegmental area of the missing tooth, means which was present earlier. Understood? We have extracted it. There won't be any perisegmental area for that at the addengerous region, but before the extraction, it was having some perisegmental area, right? That perisegmental area combined should be less than the perisegmental area of the abutment teeth, or it should be equal at least. Understood? So from this picture itself, we can understand the first picture, left side picture. Yes, it satisfies Andes law. The perisegmental area of first molar will be definitely less than the perisegmental area of the second premolar and the second molar combined, obviously, right? But in the second picture, see, canine and the second molar perisegmental area, it puts a question mark. Definitely, it won't be greater than the perisegmental area of the two premolars and the first molar. Clear? So it doesn't satisfy with the Andes law. Hope it is clear. So abutment selection, Andes law deals with the abutment selection for a fixed partial denture. Clear? Sorry. So hope the answer is clear. Everyone knows it. Andes law, it is used for the selection of abutment. Hope it is clear. If you have any problem in between, if you are not, means if I am not audible, you can message me. Clear? Yes. Now, okay, what is rest? See, rest, it is Fixed partial dentures used to have some rust initially. Nowadays, nobody used it. In fixed partial denture, rust means when you have a cantilever bridge. Cantilever bridge, what we do is from the abutment tooth, from the pondic, you will have a rust extension into the abutment teeth, which doesn't provide any support. Which portion you want to repeat? Which portion? Somebody has asked me to repeat the same question. Andes law. You want to repeat the Andes law? Just once again, I will repeat the Andes law. See, the perisegmental area. Perisegmental area of the missing tooth. The perisegmental area of the missing tooth combined should be less than the perisegmental area of the abutment teeth. Understood? So the abutment teeth should have a perisegmental area greater than the perisegmental area of the missing tooth. Hope it is clear. If you want to replace the molar, first molar, definitely the perisegmental area of the abutment teeth has to be greater than the perisegmental area of the missing tooth. That is Andes law. So Andes law deals with abutment selection. Clear? Now, rust. Somebody has asked me what is rust. Actually, in FPD, when you give a cantilever bridge, usually in the earlier days we have a rust extension into the adjacent tooth, just over the lingual aspect, lingual or the palatal aspect. That is rust as far as FPD is concerned. You have a rust, another rust, which is concerned with removable partial denture. Here, what maybe they have included it as an option. Rust we will be discussing. One question is coming in rust sheet, so we will be discussing what is rust. Okay. In removable partial denture. Okay. Now, the type, you have to identify the type of pondic shown in this picture below. Okay. Now, see, it was asked for a previous, actually 2 years back, NEET question paper had this question, this picture question, but it was not that clear like this. Okay. They didn't give the lateral view of the pondic. They didn't give the lateral view. They only gave the facial aspect. Now you have to imagine it. Facial aspect, maxillary, which type of pondic is preferred. And depending upon that, you have to give the answer. Understood? So, NEET question paper, they don't want you to answer. They want you to get confused and make it wrong. Understood? So, they won't give a clear-cut question. Understood? It will be most probably partial question. There will be less clarity in questions. Okay. Yeah. Many of you have answered. It is modified ridge lap. So we'll have to discuss different types of pondics. Clear? So pondics classification. See, basically, based upon, you know what is pondic right now, right? It is the portion of fixed partial denture that replaces the missing tooth. Clear? So you have contact with the tissue, pondic with the contact with the mucosal tissue, and the pondic which doesn't have any contact with the mucosal tissue. That is the basic classification. Okay. So which are the pondics which have contact with the mucosa? They are ridge lap, modified ridge lap, ovate, and conical. Clear? Ridge lap, modified ridge lap, ovate, and conical. Now, non-mucosal contact, sanitary pondic, it's also known as hygienic pondic, modified sanitary pondic, that is, again, it's coming under hygienic pondic itself. It is termed hygienic because it is easy to clean the beneath surface of this pondic. So it's easy to clean. It can be kept self-cleansed. Understood? So it is known as, or it's termed as hygienic. Clear? We'll discuss all these briefly. Clear? So ridge lap pondic. Ridge lap pondic, here the pondic covers the entire ridge from the facial aspect to lingual aspect, or from the facial aspect to the palatal aspect. It will cover the entire ridge. So it will cover the entire ridge. This is the ridge lap ponding. That means it laps, it covers the ridge. Covers the ridge. So that is ridge lap ponding. Okay, it's also termed as saddle ponding. Saddle ponding is another name for ridge lap ponding. Clear? So what is the problem? Actually, the advantage of ridge lap ponding is that they have good emergence profile, highly aesthetic. But the problem is that there is always a chance of food entrapment between the pondic and the mucosa. It is difficult to clean. Understood? It is very difficult to clean. That was the main issue with this pondic. Okay. So what they did is they modified it. They modified the ridge lap pondic. They removed the lingual aspect. The contact over the lingual aspect was removed. Okay. Then what we got was modified ridge lap. So modified ridge lap. The advantage of modified ridge lap was, yes, it was aesthetic because in the facial aspect, it is having contact with the mucosa and the emergence profile in the facial aspect is perfect. And lingual aspect, it's not having any contact at all. So you can clean it from the lingual aspect. Any food and entrapped between the pondic lab is usually indicated in the labial and mandible. Okay, labial aspect of maxillary and mandible ridge. So this is the common sense you have to apply when you get a pondic over the maxillary labial aspect, and labial aspect is only given in the picture. You have to put your common sense into it and remember that maxillary labial aspect, most common pondic, most common I'm saying, okay, the most common pondic, it is modified ridge lap. See, modified ridge lap, it is used in the maxillary anterior and mandibular anterior region. Okay, maxillary posterior region also, we usually prefer modified ridge lap. Ideally, it is sanitary pondic, but we usually prefer modified ridge lap. Clear? Maxillary anterior and mandibular anterior, it is always modified ridge lap. Clear? Now coming to conical pondic. See, conical pondic, it's usually preferred in posteriors where you have a knifed ridge. When you have a knifed ridge, you will have a point contact with the pondic, conical pondic and the knifed ridge. Clear? So knifed ridge, the pondic of choice, it is conical. From the picture, it will be clear for you. You have a knifed ridge, so the pondic, it will be conical pondic, point contact. Clear? Now ovate pondic. Ovate pondic, it is indicated in recent extraction cases. So you will have a pondic which is inserted or which goes into the healing socket. So what is the advantage? The advantage is the emergence profile. The most aesthetic pondic, it is ovate pondic, because you will have a natural emergence profile for this ovate pondic because you have inserted the pondic portion into means the tissue surface of the pondic is into the healing socket. Okay, so you have a good emergence profile. It will be like the tooth has been emerging out from the gingiva. Clear? So ovate pondic is indicated in healing sockets. Clear? So it is the most aesthetic pondic. Now coming to pondics which does not have any contact with the mucosa. Hygienic pondic and modified hygienic, or the sanitary pondic and the modified sanitary pondic. Coming to the sanitary pondic. Now sanitary pondic, it won't be having any contact. Minimum of 2 mm gap should be there between the lowermost surface of the pondic and the soft tissue or the mucosa. Clear? So that is the sanitary pondix. So it's easy for us to clean this region because 2 mm gap is the, you can easily clean with brush or your interdental brushes. Clear? That is sanitary pondic or the hygienic pondic. Now modified sanitary pondic, what they have done is that usually it will be buccolingual and mesiodistal convex. Now what they have made is buccolingual, definitely it is convex. Mesiodistal, they have made it concave. Now what is the advantage of getting it concave mesiodistal? The width of the connector, it is increased. I'll show you that. See here, instead of to this width, connector width, it has been increased. Clear? And here the cleansable area, the distance has been increased. Understood? So that is the advantage of modified sanitary pondic. Clear? So these are the two types of sanitary pondics or hygienic pondics. Now coming to our question. Yeah. The type of pondic shown in this figure, yeah, it is modified ridge lap. Many of you answered, but always remember the regions all these pondics are used, and accordingly apply your common sense if you have a picture type question, because definitely they won't give you clarity like lateral picture without cementation, with the cementation. All these cyclic procedure will not be shown in your pictures. Okay, so always remember maxillary anterior region, commonly used pondic, it is modified ridge lap. If it is a recent extraction socket, saddle pondic, it is same as ridge lap. Ridge lap pondics, another name is saddle pondic. I have discussed, no? Saddle pondic is another name for ridge lap pondic. The ridge lap pondic A and D, it's same, different names, same option. If you know that it's for the same, you can easily eliminate A and D. First itself, we can eliminate A and D. Understood? That is the advantage. Now, next question. Hope it is clear. Clear, right? So we have discussed 3 questions. Now coming to 4th question. Maximum tooth contact occurs during. So you have to go through the options. Lateral excursion, protrusion, retrusion, and centric occlusion. Now we have to know what is lateral excursion, protrusion, retrusion, and centric occlusion. Now coming to, we'll discuss it one by one. Lateral excursion. Yes. When we move the mandible towards the lateral side, left or right, it is lateral excursion. Any movement other than laterally or forward or backward, they are all excursive motions. And lateral excursion means towards the lateral. So during lateral excursion, definitely there won't be any maximum intercuspation on the tooth. While learning different mandibular movements, we will learn all these things, different mandible patterns, that will be all discussed in our sessions. So lateral excursion, hope it is clear. Now coming to protrusive and retrusive. Protrusive means you are moving the mandible forward, so away the condyle, away from the condylar fossa. The condyle is moving in forward direction and downward direction. Definitely there won't be. And retrusion, it's again backward. Most retrusive position is what we record during our centric relation, right? It is repeatable, and in that retrusive position we are setting the teeth. But in natural dentition, this is not the exact centric. Understood? Centric occlusion means it is not the centric relation. Ideally, centric relation is something little bit bigger. Clear? So centric occlusion, yes, this is the mandible when the jaws of teeth are in maximum intercuspation. Okay, so maximum intercuspation, maximum tooth contact occurs in centric occlusion. Clear? Hope it is clear. Understood? So, answer to our question. Again, this is the centric occlusion in lateral view. So, maximum tooth contact occurs in centric occlusion. Clear? Hope it is clear. If you have any doubt, you can message me. We'll repeat it. Clear? Now, coming to next question. Minimum distance of maxillary major connector from the palatal gingival margin. What is the minimum distance, or how many millimeters you have to keep the margin of the major connector from the gingival margin? Yes, definitely we don't keep it at the gingival margin. Why? See, we keep it at a safe distance so that it doesn't injure the gingival margin. Gingival margin are very prone to injury, and it might result in recession. Understood? It might result in the recession of the gingival margin. So we try to preserve the margin from any trauma. Now, what is the minimum distance? By heart, it has been frequently asked for your exams, competitive exams. For maxilla, it should be 6 mm away from the margin, and for mandible, it should be 4 mm away from the margin. Understood? The major connector, the margin of the major connector should be 6 mm away from the margin, gingival margin for maxilla, and 4 mm away from the margin, gingival margin in case of mandibular major connectors. Clear? I'll show you the picture so it will be more clear for you all. So, yes. From the margin, the major connector, the margin of the major connector has to be 6 mm away in case of maxilla. Understood? It should be 6 mm away. And whenever it crosses the margin, it should cross at right angle. Whenever any component of the removable partial denture crosses the gingival margin so that it can get attachment from the tooth, it has to cross at right angle to the gingival margin. It should be 90 degree. Understood? So that least trauma is occurring, or least trauma will occur to the gingival margin. Clear? So in maxilla, it should be 6 mm away. And in case of mandible, it should be 4 mm away. In case of mandible, it should be 4 mm away. The rest are the different types of major connectors, mandibular major connectors we'll be discussing in the coming sessions. Just remember that it should be 4 mm away from the gingival margin in case of mandible. Hope it is clear. So what is the answer for the question? It should be 6 mm away, 6 mm away from the gingival margin in case of maxilla, and it should be 4 mm away if the margin of major connector should be 4 mm away in case of mandibular major connector. Clear? Shall we go to the next question? Hope it is clear. Am I audible? Yeah, fine. So coming to the next question. Somebody asked me what is rest. See, in rest in mandible is a in removable partial denture. Rest in removable partial denture, that portion of removable partial denture which provides support. Which provides support. What is support actually? Support means which prevents the tissue-ward movement of the prosthesis, which supports the prosthesis, which prevents the prosthesis from pressing into the soft tissue, or which injuring excessively the soft tissue beneath the prosthesis. Clear? So rest is that component of the removable partial denture which supports the removable partial denture. Clear? That is the main function of rest. Support. It has other functions also. We will be discussing that. Okay. So the question is angulation of occlusal rest seat to minor connector from which it originates. What should be the angle of the occlusal rest seat and the minor connector? 90 degree, greater than 90 degree, less than 90 degree, less than 45 degrees. Now, what the angle important? Why the angle is important as far as the occlusal rest is concerned? Many of you have answered. I think all of you are preparing well. Good. We'll discuss it. Clear. So you have a rest seat. The main function of rest, it has to provide support. Now it has to provide, means it has other functions also. The occlusal forces or the forces due to mastication is directed towards the tooth or directed into the tooth where it rests, right? Where the RPD or the removable partial denture rests. So it has to be directed along the long axis so that it causes least trauma to the supporting tooth. Clear? When it goes through the long axis, it has very little harmful effect. The force has very little harmful effect over the abutment teeth. Clear? So how can you direct this force along the long axis? Only when it is ankulated along the long axis. Clear? So what happens if it is 90 degree or greater than 90 degree? Next picture it will be showing. See, if it is the second picture, if it is greater than 90 degree or 90 degree, definitely it will be having a lateral force. When it is pressed, it will have a lateral force over the abutment teeth. Clear? So only when it is less than 90 degree, it can direct the forces along the long axis. Right? First picture shows it. I will mark it again so that it is clear for you. See, it is less than 90 degree so that it is along directed. No, it cannot be exactly along the long axis. It will be more near to the long axis. Only that is only possible. You have to understand the clinical scenario also. So in order to direct it nearly along the long axis, it has to be less than 90 degree, just less than 90 degree, and the margin has to be rounded. Why it has to be rounded? Definitely to prevent the stress concentration. Again, this picture gives many questions or many questions that has been asked previously. The margin has to be rounded. It has been asked. Less than 90 degree. It has been asked. The floor, it has to be spoon shaped. Occlusal rest floor has to be spoon shaped. So you got 3 questions, 3 data from a single picture. Okay. So it should be less than 90 degrees. So you have understood what is rest, what is the angle between the rest seat and the minor connector, what should be the shape of the floor of the occlusal rest. It should be spoon shaped. Understood? So the answer, definitely it has to be less than 90 degrees. Clear? Okay. You can ask this, it can be less than 45 degrees. See, less than 45 degree means it will have a sharp angulation and it is very difficult. Okay. It is not possible and you have a tendency to fracture the rust at the margin, near the marginal ridge. Clear? So definitely it has to be less than 90 degree. Hope it is clear. Now coming to next question, 7th question. Minimum bone width required for placement of a 4 mm diameter implant. What is the minimum bone width? So now you have to know what are the bone requirement around the implant for an ideal implant placement. How much bone should be there? Minimum bone width for placement of a 4 mm implant. Okay. If somebody has gone through the previous question, there was a question, what is the ideal bone width and depth for an implant placement? It was given by Mish. Initially, it should have a 6 mm width and a 10 mm length. Ideal bone width and length for an implant placement. That is a data at initial period of the implant development. Now the technology has changed. Now more surface treatment has been introduced. So now the requirement is something different than the previous one. Okay. So what are the requirements for implant? What are the bone requirements for an implant placement? This is the basic one. I'm not going into the soft tissue or the adjacent anatomic landmarks and all. Buccal and lingual cortex. From the buccal and the lingual cortex, the margin of the implant and margin of the buccal cortex, there should be 1 mm width of bone. Okay. So labially and palatally, or labially or lingually, you should have at least minimum 1 mm bone width. Clear? So in order to place an implant of 4 mm diameter, what should be the width of the buccolingual width of a bone or a particular adentulous ridge? I am talking about the bone width. Okay, so we have to eliminate the soft tissue thickness again. Understood? If your question has some data related to the soft tissue thickness also, you have to reduce that also. So here the bone width should be, for 4 mm implant placement, it should be minimum 6 mm. Understood? Minimum 6 mm. Here they have not mentioned about the mesiodistal dimension. Now, what should be the mesiodistal dimension of an adentulous region placing a 4 mm implant, 4 mm diameter implant? What should be the adjacent tooth? From the adjacent tooth, you should have minimum 1.5 mm distance from the adjacent tooth. So both adjacent tooth you have 1.5, 1.5, 3 mm plus the implant diameter, that is 4 mm. So how much it will be? 7 mm minimum mesial to distal dimension should be there for placing a 4 mm implant. Hope it is clear. Now, what is the distance between two implants? You want to place two implants. What should be the adentulous span, or the width of the or the length of the adentulous span? See, from the adjacent tooth, from the adentulous tooth to implant, first implant, it should have 1.5 mm. Then you have to place a 4 mm implant. Then between two implants, you should have 3 mm diameter, 3 mm width, 3 mm width. Clear? 3 mm width, and again 4 mm diameter implant and 1.5. So for placing two implants of 4 mm diameter, what should be the span? 1.5, 4, that comes to 6.5, then again 3. That means 9.5, then again 4 mm implant again. So 13.5 plus 1.5. It comes around 15 mm. Clear? Hope my mathematical calculation was correct. Just remember that between the two implants, 3 mm diameter. From the adjacent tooth, you should have 1.5 mm. And so not diameter, 3 mm width should be the. So that gives the calculation. So you have to remember it. Between the implant, there should be 3 mm gap. Between the adjacent tooth, you should have 1.5 mm gap. Clear? Labial cortex and lingual cortex, you should have 1 mm gap minimum. Okay. So that is how we calculate. Now coming to this question. The question was, what is the width of the minimum bone required for a placement of 6 mm diameter implant? Yes, width, it has to be 6 mm, because labial cortex, it should have 1 mm implant, 1 mm bone depth from the implant over the labial surface, and lingually also 1 mm. So 6 mm. So that the answer is 6 mm. Clear? They have mentioned, or they have asked about the width, labio-buccal width or a labio-lingual width. Somebody asked me how it is 15 mm. I'll show you. See, just remember, avoid this implant. Okay. From the tooth to this implant, you require 1.5 mm. Clear? 1.5 mm plus the width of the implant, that is 4 mm, plus you have 3 mm distance between the two implant, plus another implant diameter 4 mm, plus again 1.5 mm. So how much? 3 plus 3, 6. Sorry, it's not 15 mm, it's 14 mm. My calculation mistake. 14 mm. So 3, you got 2, 1.5, 1.5 plus 3 mm, 6 mm, 10, 14. Clear? So you have to understand the scenario. It's actually, it has got a mathematical mistake. It's not 15 mm, it's 14 mm. Hope it's clear. Sorry for that. Thank you. Hope it is clear. So that is how we calculate the width for implant placement. Clear? Identify the implant component given in the picture. Implant abutment, impression coping, healing abutment, cover screw. Now we have to know all these components, right? We have to know the basic implant procedure also. We'll be briefly discussing about the implant procedure so that you get an idea about what or how implants are placed. See, remember this picture. We'll come back to the question again so that you can get, see, in this picture again, I have given the component separately, component placed intraorally, and after the removal of the component, how the intraoral region looks like. In question, in your examination, it will not be like this. Maybe they'll give only the second picture alone. Okay. I have given this picture in a sequential way so that you get to know what is this component and why it has been placed. Okay. So we will discuss how or what are the different steps in implant placement. Yes, we have removed the tooth. Either immediately we are placing the implant or we are placing the implant after the socket has been healed. We will sequentially, we will raise the flap, sequentially drill it, and we will place the implant. Now, after the placement of the implant, what we do is we close it with a cover screw. We close it with a cover screw and suture it. Okay, that is the normal routine procedure for a delayed loading protocol. There are different protocols. We will be discussing delayed protocol now. Okay. Now we'll wait for the bone to heal and for osseointegration. Osseointegration means it is the bony fusion between the implant and the bone tissue. Now, why we are placing the cover screw? What is the purpose of cover screw? See, cover screw, it is placed so that the tissue doesn't grow inside to the internal ring of the implants, internal threads of the implants, so that we can protect the internal threads. That is the main purpose of covering the crustal aspect of the implant. Clear? Now, second stage, after healing, we will raise the flap again. Now we will place a healing abutment. What is the purpose of healing abutment? So that the tissue, the gingival tissue around the implant get healed and it gets a emergence profile. The soft tissue around it get an emergence profile according to the shape of the cervical aspect of the prosthesis. Over that, we will attach the abutment. The picture 3 shows we are placing the abutment. That is not healing abutment or the healing cap. It is the straight abutment or any other abutment over which we will cement or screw the prosthesis. Clear? Hope it is clear. Now, I will show you a picture so that you can differentiate between the cover screw and the healing cap. So, this is the healing cap placed during the second stage surgery. We will raise the flap again and we will place a healing cap. Now, difference between the healing cap and the cover screw. See, after cover screw placement, there won't be anything visible externally. Understood? Beyond the soft tissue, you will not see anything. After cover screw placement and suturing, we'll completely suture it, and nothing will be visible of the implant. No component of the implant will be visible extraordinarily. Whereas when you have placed the healing cap, yes, it will project out through the soft tissue, so that the collar around the implant, the gingival collar, is shaped according to the cover screw or the healing cap or the healing abutment. Clear? Now coming to that question, you can see now something is visible outside. It is not that much projected, and after the removal of this component, you get a collar of soft tissue which has been shaped similar to the surface of the tooth, it has been shaped as if the gingiva is shaped around the surface of a particular tooth. Clear? So the component shown, it is healing abutment. Implant abutment is the portion or the extra component over which we will cement or we will fix the prosthesis. Impression coping is a component which is used to take impression. We'll be discussing in that later sessions. Cover screw, it is placed during the surgery, initial stage 1 surgery, so that there is no tissue inward growth into the internal aspect of the inner threads of the implants. Clear? So hope it is clear. So these were the 8 questions which were intended to discuss today. If you have any queries, there is a WhatsApp group which we frequently undergo discussion, daily undergo. If you have any doubts, you can put your doubts into it. If somebody who is not there in our WhatsApp group, you can message to this phone number. It is our coordinator's number, Dr. Sibi. So he will add you to the group. It is free inclusion into that WhatsApp group. So you can enter this WhatsApp group for the further discussions. If you have any doubt, all the faculties are there to clear your doubts. So if you have any doubt, if you want to know more about focus dentistry, log into thefuturedentistry.com, www.thefuturedentistry.com, so that you will get to know more about us. So hope this session was useful to you all. All the best and have a good day. Thank you. Good night.